Good afternoon, everyone. My name is Shannon Kupka. I'm a project manager working with the nursing home teams in New Mexico from Health Insight, and I'd like to welcome you to our half-hour Hot Topics series. These webinars are designed to provide you great ideas on antipsychotic reduction strategies in a 30-minute time frame to accommodate your busy schedules. They're brought to you by the New Mexico Statewide Partnership to Improve Dementia Care Work Group and sponsored by the New Mexico Department of Health, New Mexico Healthcare Association, and Health Insight. In honor of Pain Awareness Month, our previous event and today's event will feature a special educational series on pain. So we are very thrilled about today's presenter, our last event on pain education for this go round. It's on physical therapy's role in pain management, and we have Michelle Bunzel. So Michelle Bunzel is a graduate of the University of New Mexico's physical therapy program and has been a licensed physical therapist since 1996. She's part owner of 3 companies in the field of physical therapy and presently serves as Vice President of Clinical Services of PAC Ortho in Las Vegas, Nevada, and clinical consultant at Pocket Rehab and Pocket Pro online exercise and education platform. Michelle is a CPI certified clinical instructor with specialty training in serial casting, otago, gait training, basic orthoses fabrication, and treatment for neurological disorders. She's skilled at treating a wide variety of patients across many settings. So Michelle, you may get started.
Well, good afternoon. I am excited to get to speak with you guys. Our presentation today is on the role of physical therapy in pain management. We're not the terrorists you think we are. That's a little nod to my own geeky interests into Star Trek and Star Wars. So without further ado, we'll go ahead and get started. Next slide, please. So historically, physical therapists have been viewed as the bringers of pain. This is a myth. PTs tend to get a bad rap because sometimes in order to get a person moving, we have to get them to push past the pain, so to speak, in order to get better mobility and independence. Mobility and independence usually go hand in hand with decreased pain. So the problem is that people tend to remember the initial pain and then fear getting started in the first place. Please, next slide. The true focus of physical therapy is to regain mobility, regain flexibility, regain strength, maximize independence, improve safety, and reduce pain. Next slide. So when we're looking at the role of physical therapy in their treatment plan, we do need to be thinking in terms of what type of pain our patients are experiencing. And there are some very different categorizations and characteristics of pain based on when the pain started. So we have acute pain, which, as you know, the role of a physical therapist is to reduce the inflammation associated with acute pain, protect the joints, reduce edema, and encourage healing while preventing complications associated with immobility. So some most common things that therapists will do with acute pain is RICE, which is an acronym for rest, ice, compression, and elevation. The use of modalities such as heat, ice, ultrasound, iontophoresis. There are several others as well that are available out in many therapy clinics in order to try to help reduce pain. Moderate activity. So the reason we get people moving even in acute pain is because we're trying to prevent other complications that are associated with immobility, such as pneumonia. We try to prevent bone and muscle loss and prevent stiffness or contractures occurring at joints because of that immobility. And then we help patients to adapt their activities by the use of, for instance, assistive devices like walkers or canes, or we help them to modify movement patterns in order to try to help minimize the pain without completely reducing their ability to get up and move. Now with chronic pain, the role for a physical therapist is to help decrease that chronic pain through movement. Many conditions have had lots of many sources that have shown that they help to reduce pain by using physical therapy, such as osteoarthritis, fibromyalgia, chronic headaches, rheumatoid arthritis, cancer, neuropathic pains or pains that are caused by injury to tissues or nerves, and many long-standing orthopedic conditions can be improved upon by physical therapy to help reduce their pain. Next slide. So some qualities of these pains. For instance, acute pain, just to kind of give you a little bit of a quick review. Acute pain is typically more intense than chronic pain. It usually comes on suddenly, and it's usually caused by something specific, a specific action or an injury, something that they can actually point to and say, this is when I started hurting. It's usually sharp in quality. Acute pain usually does not last longer than 6 months, and there's actually some validity to saying that after the first month, acute pain becomes a subsection, more like subacute pain. But for the purposes of this presentation, we're just going to keep the two classifications. It usually goes away when there is no longer an underlying cause for the pain. And usually some typical causes of acute pain are surgery, broken bones, soft tissue injuries, dental work, burns, cuts, and wounds. And though this is not as likely in our patient population, labor and childbirth are considered acute pain. Once the injury has healed, though, with acute pain, the pain usually goes away. Now with chronic pain, the underlying acute injury or the insult to the body has probably passed, but that the pain lingers due to many different factors. Most of them are associated with limited movement due to the immobility during the acute phase, and limited strength due to the avoidance of activities during those acute phase injuries and pain. So it's typically less intense than acute pain. Most patients that are experiencing chronic pain is more of a dull pain rather than a sharp pain. But the pain manifestations with chronic pain become much more complex, and you may see patients who complain of many different types of pain that are chronic, as opposed to acute pain, which usually is going to be intense and sharp in nature. With chronic pain, we actually can see an emotional manifestation associated with the pain because they have been dealing with this for a longer period of time. Usually chronic pain is considered longer than 6 months of experience, which, as you may have experienced with a lot of your patients, once they have had to deal with pain for such a long period of time, they become a little bit more emotionally labile. They are higher incidence of depression, and recognizing that is coming because of their pain is a big part of helping to recognize how you can help them to overcome those issues. And then, of course, some people can develop a fear of movement and activity because of their pain, and that helps to also contribute to the continuance of their pain because of the immobility and the strength loss that occurs because of that. Next slide. So the role of a physical therapist in pain management. Physical therapist involves a number of different types of pain management methods in order to try to help alleviate those things and allow for patients to regain independence and mobility, such as using massage, heat and or cold therapy. There's a lot of different modalities out there, but heat and cold are very, very helpful. They have the highest improvement and benefits with the lowest number of deficits or problems that can be occurring with them. A lot of times therapists will also use manipulation of joints and or bones to help break up adhesions, so that can help to improve flexibility, therefore decreasing pain. You can also use manipulation of joints and bones in order to release endorphins, which are natural pain reducers to help reduce pain. Manual therapy, so using hands or tools on soft tissue to improve flexibility. Microcurrent, which is another type of modality, it emits alpha waves into the brain so that it helps to increase serotonin and dopamine levels to help alleviate pain naturally. And then we also use TENS and NMES, which is the nerve stimulators, and ultrasound modalities to help reduce pain initially, especially to help to release those endorphins for longer lasting relief. Many of you may have seen patients using TENS or ultrasound, and those are supposed to help reduce pain while they're being used, so the actual action of using them, but they also are supposed to, if they're being used correctly, they are supposed to increase the amount of endorphins that are being released into the body so that they have a longer lasting effect. So when you take off the TENS or the ultrasound or the NMES machines, that they actually get some lasting pain relief once the machines have been turned off. And then of course, our biggest way that we help to reduce pain is by movement therapy and exercise. Next slide. So PT treatment is customized to the individual. So it's important to recognize that all treatment modalities, no matter what you're doing, can have a really helpful way in reducing pain, but it can also be very harmful. So it's important to understand the underlying cause of the pain, recognize what kind of pain it is, whether it's acute or chronic. And so it's just important to recognize that evaluation is the key. So it's not enough to just say, oh, a therapist isn't going to just go, oh, you have pain, I'm just gonna work on these particular things because they always work. We're going to take a really comprehensive look at those patients and figure out exactly what's causing the problems, what things I can affect and what things I can't, and then helping to share that with that patient as well so that it is customized to their needs and their individual deficits. Next slide. Now, as a therapist, it's one thing for me to go in there and be able to do things to try to help reduce pain and improve mobility with a patient, but really pain control is a team approach. And so I wanted to give some suggestions of ways that the rest of the team can help me as well as a therapist as well in order to help reduce pain. So a therapist, if I've got some PTs, OTs, speech therapists out there, a really helpful way to reduce patients' pain is to help communicate your patient's schedule to the patient, to the nursing team, to all the other therapies, so that they understand when you're going to be working with that person, so that patient can actually take the time to do things that they are able to do before you have therapy in order to better prepare for reducing pain. Nurses can encourage patients to take their pain medications about an hour before therapy, especially if they're PRN medications. A lot of patients think that they only need about 30 minutes to take their medication, but as we get older, our ability to process those medications through our GI system takes a little bit longer sometimes. So we usually ask that patients take their medication about an hour before so that they really are taking effect by the time they start their therapy session, and they can actually use the benefits of those pain medications in order to participate fully during a treatment. Our CNAs, if you give your patients extra time to get up and perform their transfers and prepare for therapy, that can be a really helpful way to reduce pain and help that patient continue to make progress towards reducing their pain long term. Moving too quickly can make pain worse, so taking the time to give them that opportunity can really be a godsend in helping them to really be able to be successful during treatment. Restorative nursing. One of the biggest things that I can stress on restorative nursing is that consistency to the activities that you're doing is really key to helping to prevent loss of function. And if you schedule patients very regularly, you get a much better response from them. So missing visits or clumping your visits too closely together can actually aggravate painful conditions. So just trying to keep a more consistent schedule with your patients as you're doing their activities. And then of course, caregivers and everyone else who comes in contact with those patients, communicating your patient's response to activities to the nursing staff, the CNAs, the restorative aides, and then also of course to the therapists, letting us know how they are being able to perform those activities outside of their therapeutic activities so that we can make adjustments to those therapies as needed to try to help alleviate pain or prevent aggravating other systems. Next slide. Everyone can help to reduce pain and prevent pain. There's a lot of research out there that shows that 30 minutes of moderate, appropriate exercise performed 3 or 4 times a week will help to preserve flexibility, increase strength, improve circulation, improve joint stability, increased endurance, and reduce pain by way of the above benefits. All of these things help to alleviate pain, as well as moderate activity has been shown to improve the release of endorphins, such as serotonin and dopamine. Next slide. A lot of times when you're coming in contact with a patient, they may ask you questions about what's appropriate, how can they exercise on their own, what kinds of things that they can do. So some things that you can actually tell your patients that is appropriate ways to answer that question is that patients really should go at their own pace. They should not do anything that their PT or their doctor have not told them to avoid. Mild discomfort, such as soreness or tightness or a warm sensation, like a 1 to 3 on your 10 out of 10 pain scale, is normal initially. If they're continuing to have that long term, they need to tell their therapist so that they can have their program adjusted. If they're experiencing pain, though, that's significant, so 6 or higher, then they need to either modify the activity, make it easier, do fewer repetitions, or stop doing it. And then tell their physical therapist or their doctor so that they can adjust those programs to meet their needs. Next slide. So the appropriate use of heat. The reason I wanted to go over this was because a lot of times as I'm going through facilities, we've got some sweet little ladies who want to have their heating pad on all the time. And there is some research that shows that's actually really detrimental and can actually increase their pain over time and cause longer chronic conditions to continue. And the reason why is because you're really only supposed to use heat for 20 minutes at a time. Anything longer than that can contribute to damaging tissues and increase your likelihood of developing chronic pain issues. So always set a timer if your patient is wanting a heater, so that, or a heat pad, so that way you can make sure that they are only using it for the appropriate amount of time. Always use a protective barrier between the patient and the heat source, such as a towel. And that way you can help to dissipate that heat a little bit and help to prevent any burning that can occur, because these hot packs are sometimes pretty hot. Following heat with stretching and or exercise can help to maximize the benefits of the heat. So it's really great that if a patient really wants that heating pad, once the 20 minutes is up, going in and encouraging them to then do their exercise program or to do their stretches. Now that their muscles are quote unquote warmed up, they can help to alleviate the need for those services, those heating pads later on as well. And then never, ever, ever use heat on a body part that has impaired sensation or circulation unless you've been instructed by the PT or the doctor and that you follow the modified parameters for that heat exactly. The reason this is so important is because even with just impaired sensation, not even lack of sensation, patients have associated decreased circulation in those areas as well. And you can actually cause a burn with even a lower heat for even a shorter amount of time. I've actually had that happen to a patient. He was assured me that he had great pain or great sensation in his shoulder. His light touch and pinprick tests seemed normal, but he did have a stroke on that side, and after 10 minutes of using a heating pad, he did develop a blister on his shoulder. So it's important to really watch what they're doing, and if you're at all unsure if they have impaired sensation, don't use it. Next slide. Now, the appropriate use of ice. I love ice. Ice actually has even better benefits and fewer side effects. But again, it needs to be used correctly. So of course, when you're using it, you want to make sure you're using a protective barrier like a towel placed between the skin and the cooling surface. You can use ice directly against the skin, but you do want to make sure that you're being careful and that you are setting a timer. Ice, especially if it's being used directly against the skin, should only be used for 20 minutes. So just like with heat, 20 minutes, ice, 20 minutes. If you use it longer than that, directly against the skin, you can cause damage to tissues such as frostbite. So you want to be careful. Following up ice with activity to maximize the functional independence while pain is helping to reduce your pain, or while ice is helping to reduce your pain, can be really helpful in regaining that independence. And then of course, same thing with ice. If you have impaired sensation or circulation, don't use it unless you've been instructed by your physical therapist or your doctor, and that you follow the modification parameters exactly. Next slide. These are just a couple of references that I used in order to help get this presentation set up for you guys. Next slide. So now we're at the questions portion of this presentation.
Okay, so we will give you a minute to collect your thoughts and enter any questions that you might have into chat, please, or you are welcome to raise your hand. There's a little opportunity to be able to do that. I have a question from Skitch that I'll start with, which is, does physical therapy help somatic pain?
Physical therapy indirectly helps with somatic pain. The mobility and the independence that patients gain help to regulate their pain and help to reduce, release endorphins in order to help reduce some of the pain associated with somatic pain.
Okay. Risa asks, if therapy is treating chronic pain, does the benefit only last as long as they are in therapy?
No. The idea of therapy is actually to work ourselves out of a job. We want to teach our patients and their caregivers how to appropriately manage their pain so that they don't need us anymore.
Okay. Okay, a couple more questions. Rochelle asks, what grade mobilizations do you typically use on elderly patients / residents to decrease pain, and how long do you typically provide this service?
I typically do not do mobilizations in this way because I am not as strongly skilled at it. I usually use much more lower grade, so I use mostly stretching and arthrokinematic movement patterns rather than true joint manipulations. The information that I provided about joint manipulation in the presentation was purely from research showing that can be very helpful and effective. I'm sorry that I can't give you a better answer on that one.
Okay, thanks. And Skitch asks, how about cranial work? Will it help migraine sufferers?
Again, I'm actually not craniosacral certified, so I'm not sure how that helps with that. The only research that I have looked at previously in regards to helping to reduce headaches had to do with reducing tension. So massage therapy, ice therapy can be very helpful, and biofeedback, as well as good arthrokinematic movement and motion, figuring out where the headache is, what's being caused by, and whether or not that's something that physical therapy can actually intervene upon.
Okay, great. Laura asks, what is the best approach for neuropathic pain?
Well, a lot of times with neuropathic pain, we're having to figure out how to figuring out what the appropriate pain medication would be in order to help alleviate some of that so that we can get that mobility back. I am not able to, for instance, I'm not able to make a big change in, say, diabetic neuropathy because the damage to the nerves are already there. What I can do is try to help continue their flexibility and their mobility so that we get the best circulation we can to the area to help prevent it from getting any worse. And then, of course, follow that up with information to the doctor so that they know what medications are working for that patient and what aren't. There are a lot of pain medications out there, and not all of them work the same way on every person. So knowing what's worked in the past and what's not working can be really helpful too, and getting that communication with your doctors.
Okay. Skitch asks, what can non-PTs do to help bedbound persons with range of motion?
There is a whole series of exercises that we can show you that are we call them active assistive, because we want the patient to do as much as possible on their own, but ways to help the patient move through the full ranges of each joint without putting yourself at risk, because you're going to be holding and lifting. That would be a whole new presentation, but there are plenty of ways that caregivers can really help with a bedbound patient by assisting them through movement, even in bed.
Great. Okay. And if, I don't want to put you on the spot, Michelle, but certainly if there is interest in that kind of a presentation, let us know, and we just might be able to get Michelle to come back if we ask nicely.
That might be good, because then I could get up and not be so nervous and sitting talking. I could demonstrate some good exercise.
Pretty cool, actually. Does anybody else have any questions in chat? Anything that we missed? Or again, questions around how to have your staff in better communication around goals and activities that are happening with their pain? I'll give you a second or two to think about that. Good questions though, everybody. Okay. I am not seeing anything else in chat, so I'm going to, if we've missed anything, again, please, you've got another minute or so before we end, so feel free to chat that in. But I wanted to make sure you knew that the presentation is going to be posted to our website in a couple of weeks, and I've put in chat the link to all of our posted webinars. So please take a look at that. And also we have a great nursing home resource library with information, resources, tools, and training for you. So please share this with any of your colleagues who couldn't attend. And because these are so short, we encourage you to use this webinar series as a way perhaps to in-service some of your staff, again, who might not be able to make it in real time. Again, for CEs, New Mexico teams, please make sure that your name and all attendees, if you're attending in a group, are represented in chat or emailing to me afterwards so we can send you a test link. And we'll be having another hot topic session on October 19th. We're going to revert back to the land of antipsychotics again with our hot topic, what is Lewy body dementia? So we invite you to come back and join us again when that happens. Once again, I'd love to say thank you very much to our presenter, Michelle Bunzel. You did a phenomenal job, and clearly from all the great questions, I think this is very necessary information. So we really appreciate you being here and your willingness to speak with us today. Thank you.
Thank you for having me.
So I'm going to release you all back to your day 1 whole minute early. Enjoy yourself. Have a great weekend. Thank you so much again for attending Hot Topics. Take care, everyone.